Good evening and welcome to my YouTube channel Pain Free Partha. Subscribe and listen until the end. So today we are going to talk about measurement of pain. So already we have told in the different video that pain is multidimensional. It is sensory, emotive, psychological component and all. So now we are going to talk something about measurement of pain for adults in the next 20 minutes. So our greetings from Mahatma Gandhi Medical College and our Director of E-Learning, Professor Ravi Shankar, and why we need this topic. Whenever I say anything, why we should know this topic, that's my first slide usually. So pain is not very simple and it is subjective. It's very difficult to objectively measure. So for example, if you have blood pressure, it will increase or decrease. It's objective sign. So it is subjective. Patient has to tell. It is multidimensional, sensory component, emotional component, and it differs with the day, the patient's age, what are the drugs, what is the environment, what is the psychological effect, what is the type of personality, so many things. So measurement of pain is significant in this setting. The first man to tell was long back in 1948 key. He said mild, moderate, severe. This is what is the first time it was told, but still it is remaining. Mild, moderate, maybe moderately severe and very severe. So the four things are come, but still in 1948, what Kayles told is still remains. I wanted to just tell locus of control. Locus of control is an internal focus, means this fellow believes that all the problems are due to themselves only. But locus of control is external, means he has got other influence for us. So why this is needed? A person with internal locus of control may be beneficial with PCA, and external locus of control may be beneficial with nurse-induced analgesia, nurse-controlled analgesia. So that is the difference. So even this is different. The fellow has got an internal focus or an external locus. In the post-op ward, yes, we measure pulse, blood pressure, saturation, temperature, respiration, BP and all, but we may need to measure also the pain. So how do we measure pain? It's a separate language. Already it is told, that is why it is very difficult. There are two things in this. Pain intensity, it's very severe is one thing. Pain affect, how much it is affected. He starts to cry. He starts to get depression. He starts to get suicidal feelings. Pain affect. Sometimes your intensity and affect may not correlate. Your intensity may be 8 and affect may be very less. And sometimes the intensity is only 2 and affect will be very high, especially in chronic pain. So the affect portion will be more in chronic pain than intensity. That is why the measurement of pain in chronic is slightly different. They go into satisfaction score, they go into disability score, all these things when they measure resource, how much time they have taken leave in their office, all these things they measure also with intensity in terms of chronic pain. We all know that already we got told work situation, prior injury, everything will change. Perception of pain may differ within a time period. 1 week, then to ask for current pain at a specific time, say now the patient is having pain. Severe, it is very severe, unbearable. And if you ask after 2 weeks, how was the pain that time? He will tell not much. So it may differ within a time period. That is, so maybe after 1 or 2 weeks they may correlate, but after that it may not correlate. Now, if you ask the child is around 3 years, how was the labor pain and all? The answer was nothing. This is our article or reported pain during labor. Qualitative influence. This pain was taken 6 hours after delivery. How was the pain like? That is why it is called reported pain. So we correlated well with this. Now we will go to directly to our topic. Verbal rating scale. This is one of the measurement scales available for pain. And it's very severe. 4, 3 or 6 words. Mild, moderate, severe. Mild, moderate, severe, unbearable. All these things are there. This is what is about verbal rating scale, VRS. Now we have a visual analog scale. This is no pain and this is pain as it could be. Now the patient touches here, then you go to the back side of it, it will be showing 3.5. So this is a visual analog scale, which is usually doesn't have numbers straight. Sometimes there may be grades of shade. They will see like this. If you go to the back, it will say 7. So this is what the scale is like this, or sometimes like this. So if you go to the back, it is, then the scale will be like this. Okay. The scale may be sometimes like this also. This one 0, 1, 2, 3, 4, 5. When you have numbers from 0 to 10, where 0 means no pain, and 10 means unbearable pain which he or she may ever think of in life, it is 10. So the patient will tell 6, 7, and all. And if you add some colors like green, yellow, and red, the patient will have some more punch into what they are telling you. Yes, this is what is called sometimes NRS can be from numerical rating scale from vertical scales also. And this may be associated with some behavioral photos. This is fine, this is okay, and this is red. So they may have some idea. This is behavioral scale touched NRS. Pain is overestimated when actually is higher and underestimated when it is lower. So for example, if a patient has got 3, he may tell 2, and if he has 7, he may tell 9. That is what is the problem now. Problems with assessments. What are the advantages of this numerical rating scale 0 to 10? It is very simple. It is okay, sensitive. And it is easily reproducible. Again, you tell, after 1 hour, he will tell. It is quick, hardly it take less than a minute. It is cheap. How much it will going to cost? So these are all the advantages of numerical rating scale. You will tell 5. Then after some drugs, you may tell 3. So this is very simple. It is not that the numerical rating scale can only use for pain, but actually the discovery or the invention of the NRS came for some other thing like patient satisfaction or something like. Yes, both vertical and horizontal are there. But what are the disadvantages? Now, it is difficult for the patient to understand. For example, the patient will be in severe pain. If you ask, pain is very severe. And if you ask the numerical rating scale, it will be 3. So it is very difficult for them to comprehend. Yes, it is very difficult. Sometimes resting PRS, NRS, and movement NRS. The commonest movement after laparotomy of this thing is cough. That is very important. On cough, the patient will scream. So it is not that the patient should walk and all. Even a cough is a movement for an laparotomy. Chronic pain changes, it should be 20%, and at least 12%. I consider 20% changes clinically useful. For example, if the patient has got 9, then it has to come down to 7. Then you can say the drug is useful. So this is very important. There are a lot of things in this. Some say even 3 NRS reduction is important. So it is similar to PAS, 0 to 10 numbers. Yes. This is what is a simple numerical rating scale. There are 5, 10, 100, 20. So they have proved that 0 to 10 scores are ideal. And in elderly, these scores are not dependable. That's what we told. Sometimes they'll say very mild pain, and if you say NRS, it will be 7. So this is somewhat, especially in elderly. You need to have good cognitive function for this. That's the problem. If you have post-operative cognitive dysfunction, how can you measure this numerical rating scale? With other pain assessment tools in several studies, the feasibility of its use, good compliance, it is easy to administer verbal. It is very important. Telephone also we can ask. If he goes home, 7th day, ask, what's the pain? Now it is 2. This is the advantage of NRS. But I feel it needs a 20% change. Reported, usually patients report pain to nurses, but sometimes they can report also to physicians. It's a study which tells that if the patients report to physician, they report more pain. If they report to nurses, they report less pain. It's a very important study actually, because usually these are managed by nurses. So there is a study which tells patients report less pain to nurses. This is one study which tells a minimum of 1.3 centimeter reduction when it comes to acute abdominal pain in the emergency scale. This is what is needed in VAS. There are so many things. The most important problem of these scales, verbal rating, visual analog, numerical rating scale, is unidimensional. The intensity of pain only, not the other psychological effect, social effect. All these things are not there in NRS. There are a lot of other measurement scales which we brush up first. This is something called quiz. Now I told you the NRS is a unidimensional scale. Now you see quiz. In quiz, there is severity. This only manned by your NRS. This quiz scales one part of severity alone is done by the NRS. Now you see quiz the quality, the impact. How does the pain affect you? The site, where is it? And severity. This is what is called the quiz scale. Now there is something called Socrates scale. Site, onset, character, radiation, associations. But the very common association with pain is nausea, vomiting, sweating, especially renal pain. This is associated with nausea, vomiting, and sweating because there is intense autonomic connections between renal nerves and autonomic nerves. So this is what associations. Does the pain follow any pattern? What are the relieving factors? Severity. See here in Socrates, only yes is found out in NRS. There is something called MPQ, McGill Pain Questionnaire. It was found out by this person. Sensory, affective, and emotional components of pain are addressed. Sensory, affective, and emotional. See, crushing, throbbing, cramping, spitting, cutting, shooting, etc. There are so many things like this. 1, 2, 3, 4, 5, 6, up to 20. One or two word descriptions into 20 subclasses. For each subclass, the patient has to tell the description and also the score. Pain rating index, number of words chosen, present pain intensity, all these things can be calculated in MPQ. So this can be what you think of, one or two, and it is you cannot again repeat. No, sometimes this is wrong. You have to repeat after 20 minutes, which is very difficult because one or two, 20 sets, data analysis, all components assessment of therapy is very excellent in terms of advantages. It analyzes everything. But disadvantage is patients become frustrated, we become frustrated, nurses become frustrated. And you should have very good knowledge of so many tricking words in English, and it has to be pakka translated into the language of Tamil English, Tamil Marathi, or Telugu, or something else. So this is the problem with MPQ. There is a short form McGill Pain questionnaire where there is only 60 passes there, PPA is there, less fast, less frustrating, but still it has 60. This is the short form. Now I want to tell an idea of various types of pain with regard to MPQ scorings. Now if you take sprain, it is 20, 10. Toothache is 20, fracture bruises is 10, thymy is around 32, causalgia. See here, causalgia is 40. LVA, cancer, post-herpetic neuralgia is around 35. This is what we need to have a focus of how pain intensity is different in different classes of diseases. Now we have adult non-verbal pain scale. For example, the patient cannot speak. Okay, he has got a tracheostomy, whatever it is. Now, how will you calculate? I cannot tell 3, 4. You can tell sometimes 4. Or if the cognitive dysfunction is not much, you can have face, you can have activity lying quietly, seeking attention, restless. You can very easily see the patient nicely sleeping, eyes closed, breathing is normal at 12 to 14 per minute, and pulse rate is around 70 means good pain relief. If the pulse rate is 95, the breathing rate is around 20, and the face is like this, some sweating is there, yes, then the patient is in extreme pain. So you need not ask any question to the patient. All these things will come like this. There is something called defense and veterans pain rating scale. Here he has to tell for activity, sleep, mood, and stress. They have to score each and then compound it into a total sum of numbers. Pain assessment in advanced dementia, how it is possible? Again, telling negative vocalization. He's telling something which is not related. Okay, if you ask how much is the pain, he can tell I am having nausea. So this is negative vocalization. And facial expression is bad. Body language is so consolability is not there. So all these things make high scoring systems. So advanced dementia scale, pain ad. This is behavioral pain scale, again facial expressions, upper limb and breathing. There is something called Mankowski's pain scale. Again, this is a 10. There is only one difference. In 10, the patient is unconscious. So much pain is there, the patient is not responding, and even the strongest painkillers are not much effective. So this is what is the. So now it can't be ignored for more than 30 minutes. Mild painkillers like tramadol may be effective. A strong painkiller, yes, difficult to concentrate, interfere with the sleep, yes. What is PQRST scale? Provocation, quality, region, severity, time. What provocates? How is the quality? Where is it? Radiating or not? How much it is? Where the NRS comes? Timing. Now we can see when did the pain start? Constant or intermittent? Severity, region and radiation, quality, provoking or relieving factors. This is what is called the PQRST scale of pain. Now, many people will say, I'm having 7 by 8 or 7 or 8 in pain, but patient will be comfortable. So that is what is the confusion. So they may tell the comfort score and pain score. So sometimes this comfort score and pain score may not correlate. He may tell 4 by 10 for pain and 2 by 10 for comfort. So clinical assessment is state of discomfort. There is something called clinically aligned pain assessment. Same thing, you can see comfort, change in pain, pain control, functioning, and sleep. Same thing will come again and again. Is the patient sleeping? Is the breathing okay? Is the pulse rate okay? Is the fellow is sleeping well? So all these things, different clinically aligned pain assessment. It is not only telling about pain control and change in pain, it is about functioning and sleep and comfort. So there is something called Holder scale. Character, onset, location, duration. Very important. This is important in timing is there in some scales. Duration is here. Exacerbation in one scale. Provocation in another scale. Relieving, provocation slash relief in PQRST scale. Radiation. What is dole? Dole is an SI unit of pain. It's an SI unit of pain. A unit for the measurement of pain intensity, which takes 1/10. It is very difficult to understand this. What I have comprehended is, for example, it's a 0 to 100 scale or 0 to 10 scale, and the patient is telling 6 or something like that, 6.5, only 1/10 of it, 0.65. Dollars. Dolorimeters apply steady pressure like this. See here. They study pressure and find out. There is something different scales up to 70 are there. It depends upon how much is the testing. Oswetry Disability Index, Roland Morris Disability Questionnaire. All these things are about chronic pain. For example, on osteoarthritis pain, how far is the disabled? Important. So VRS and NRS remain standard. VRS means what? Verbal rating scale. Mild, moderate, severe, very severe, and unbearable. This is VRS. NRS is 0 to 10. So there are a lot of scales like PQRST scale, Calder scale, Socrates, so many things, McConsky scales. McGill Pain Questionnaire, short form and long forms are there, 102 and 60. How each will tolerate the pain is different. Sometimes patients, even if you push some drug into the cannula, they'll scream. Some patients, even they will not know if you insert an 18 gauge cannula. So that is the difference. That makes assessment of pain very difficult. Thank you very much. I can be visited in www.painfreepartha.com and my YouTube channel, Pain Free Partha.